Good afternoon. We are going to talk about diabetes, specifically DKA versus HHS. Make sure you review all your diabetes content, especially medication. It's essential to understand how diabetic medications work in the body, for us to keep our clients safe and to also educate them about their medicine. But let's just quickly review the pathophysiology of insulin. So I wrote up here what it does in our bodies. For a non-diabetic client, when we eat, food breaks down into a lot of things, but we're going to focus on glucose. Food breaks down into glucose, and then the insulin is able to change that glucose into energy. So our bodies can utilize that energy if we need it, or we can store that energy. Insulin can take glucose and store it in the cells, specifically liver, muscle, and fat cells, if we need to use it at a later date or a later time, okay? Well, let's think about a diabetic client. Diabetic clients either have no insulin, so we're going to think type 1, where there's a destruction of our beta cells in our pancreas, therefore there is no insulin in the body, or we're going to think about a type 2 client who has a lack of insulin in their body, or insulin resistance, meaning insulin is not as effective and it does not do as well of a job, for instance, in transporting glucose into cells, okay? So these clients, when they eat, food, again, is broken down to a lot of components, but we're focusing on glucose. So glucose is in our body. Well, there's no insulin or decreased insulin, so glucose therefore cannot be converted into energy and cannot be stored into cells, because we need insulin to transport glucose into our cells. So if we can't do these things, what happens in our body? Or we're just going to say in the body of this diabetic client, all the glucose stays in our blood, and it elevates our blood glucose level, causing hyperglycemia. Well, when this happens, when hyperglycemia occurs, I automatically like to think about my 3 Ps, because our body will fight. We will cope. We will always try to adapt to a change in homeostasis. Hyperglycemia is a change in our homeostasis. So let's think about what our body will do. So we have glucose in our body, but it's not in the correct place. We have all this glucose in our blood, but we need our glucose in our cells. We need it there for energy. We need to store it when we need energy at later periods of time. But our body doesn't know our glucose is in our blood. It just knows that the glucose isn't in our cells. So our body's going to trigger us to eat more, because a diabetic client, and I say us, but let's pretend we're talking about the diabetic client. Our diabetic client has glucose in the body, but not in the correct spot. So our body's going to cope and trigger them to eat more, because again, they're just starving for energy. They're starving for that glucose in their cells, so they're going to eat more, causing polyphagia. Well, again, our body's going to cope and adapt, and all this glucose is in our blood. Well, what are our kidneys going to do? Our kidneys are going to try to cope and help with that problem by starting to pee off all this glucose, okay? So we have polyuria. However, we're not just peeing off our glucose, we're peeing off our fluid. So now with all this polyuria, our kidneys have tried to help by getting rid of all this excess glucose, but we are now losing fluid that we need. So the diabetic client starts to become dehydrated. And then your body again is going to try to adapt. Because of that polyuria, we've lost fluid. It's going to trigger the body to say it's thirsty. So that's why we have polydipsia, because we're losing fluid along with that glucose. We want our thirst mechanism to kick in, so hopefully we'll drink more fluid, okay? So that's just the typical patho of insulin. I always like to think about my 3 Ps with my diabetic clients, okay? So let's really break down the difference between DKA and HHS. The big difference, what you really need to focus on, is DKA, you're going to think there is no insulin in the body. No insulin in the body to transport glucose into cells, okay? So your client's body is starving for energy, versus HHS, there's a lack of insulin, but there's still enough insulin there that some glucose is getting into the cells. So this client is not starving for energy, okay? They still have enough insulin in their body to effectively change glucose into energy and to effectively store glucose into the cells, that they are not starving for energy. That's how I like to differentiate between these 2 disorders. But let's start. We both know each disorder is attributed to elevated blood glucose, okay, or blood sugar. So we know they will both have the 3 Ps: polyphagia, polyuria, polydipsia. I really want to focus on polyuria. because when you're thinking about priorities for DKA and HHS, you need to think circulation. So elevated blood sugar in the blood, elevated blood glucose in the blood, our kidneys try to cope by peeing off this glucose. Well, we also lose our fluid. So now this polyuria is going to make symptoms of a dehydrated client. So what are they going to look like? What is your assessment going to look like? Let's talk about vital signs. We know they're dehydrated. So they're going to have decreased blood pressure and elevated heart rate, because you know we're going to fight. Yes, we're losing our fluid, but our heart's going to pump faster to try to circulate more fluid. They're also going to have dry mucous membranes. And let's think about our lab values, okay? Let's think about our lab values for a dehydrated client. Your BUN and creatinine will be elevated, okay? And again, this is universal for HHS. Same thing, they have polyuria, all right? They will have decreased blood pressure, elevated heart rate. They will have dry mucous membranes. And their BUN and creatinine will be elevated. Because our priority for both disorders is circulation. So our polyuria has created a dehydrated picture of a client, so circulation is our priority. How are we going to act? Okay, what is going to be our priority intervention? And we need to think fluids, okay? These clients will get bolus with a lot of fluids. A very common fluid we use is 0.9% sodium chloride. And same with HHS. You need to think fluids. They are going to get fluids. And again, primarily we are bolusing them with 0.9% sodium chloride or normal saline. And we're going to talk a little bit about how the picture can change and what we might have to use different fluids depending on the scenarios. But our priority for both DKA, HHS, circulation, we're bolusing these clients with fluids. Well, we also know they have elevated blood sugar. So we should think we need to give them insulin. And the type of insulin, this is a dramatic increase in blood sugar to the point where it's now affected our kidneys, and our kidneys are trying to cope by peeing off glucose. So the appropriate type of insulin for DKA and HHS is IV insulin. And we only give short-acting IV insulin, so you should be thinking IV regular insulin for both sides. And we should always think that, of course, they will constantly have their glucose levels checked. It will have to be on a pump. We only administer IV insulin via a pump. And like I said, we will be giving a short-acting insulin, okay? Now we're going to start to get into the differences between DKA and HHS. So on this side, I'm going to put no insulin. If there is no insulin, there is no way to transport glucose, convert it into energy, and also put glucose to where we need it in the cells to be stored for later. So our body is starving for energy. There's no insulin, there's no way to change that glucose into what we need for energy. So what's going to start to happen is your body, again, is going to try to cope and adapt. And it is going to start breaking down other cells for energy. So one cell in particular it will start to break down is your fat cells. And when we break down fat cells, because your body is trying to cope and create energy, you form ketones. And ketones are an acid, okay? So let's think about this. We now have increased acid in our body, all right? They will test positive for serum and urine ketones. And let's think about, this will start causing an acid-base disorder. We have increased acid in our body, so our pH will start to become less than 7.35 because we're creating a more acidic state. And we should always remember, if our pH is going into acidic state, our body tries to cope with our buffers, with our lungs, with our kidneys. But with our buffers, if we're going into acidic state, it is going to try to take your hydrogen ion in your blood and push it into the cell to try to decrease the acid in your blood. Well, what pops out? When we think an acidic state, we should always think hyperkalemia. So we have a low pH. We're starting to get an elevated potassium level because our buffer system try to shift the ions around. They try to move hydrogen ion, which we know is the acid, into the cell. Well, we can't move something into the cell, we'll take it without taking something inside the cell out into the blood. So we take potassium in our cell and move it outside of our cell. So now we're starting to have an electrolyte imbalance. And we should also be thinking we're in an acidic state, we have hyperkalemia, and we have to think about, what do we now have to do? How will our body continue to cope? Well, that's why we're now in acidic state. If you see somebody in DKA, you'll see Kussmaul's respirations. So I'm going to say assessment. And I'm going to put Kussmaul's. Well, let's think about why they're in Kussmaul's respirations. They're in an acidic state. So Kussmaul's respirations, they are hyperventilating. And when they're hyperventilating, this is a coping mechanism. They're in an acidic state. The body will try to excrete excess CO2, because CO2 is the acid, to try to help this acidic disorder. So that's why you see somebody in DKA with Kussmaul's respirations is actually a coping mechanism to try to blow off more acid from the body, okay? Well, we need to think, what do we now have to do specifically to this acid-base imbalance, okay? Some interventions. The client needs to be on an ECG monitor. We need to be drawing frequent fluid and electrolyte levels, specifically potassium levels. And we need to think about, how do we fix this disorder? Well, truly, if we remember back to pharmacology, we are now in an acidic state. We are hyperkalemic. We're putting them on an ECG to monitor their heart level. We need to be monitoring their level of consciousness. But if we think back to what insulin does, okay, insulin, yes, will decrease the glucose in the blood, but insulin also helps to shift potassium back into the cells. So insulin will also assist with this acid-base imbalance by pushing potassium back into the cells for very, very severe states, when the body starts to decompensate related to acidic level. They can also administer sodium bicarb. That's for a very severe state, okay? And let's talk about HHS. We have insulin, so therefore there is no breakdown of cells, which equals no ketone production. So somebody in HHS, they're not going to be in an acid-base imbalance because they have enough insulin in their body to transport some glucose into cells and to utilize glucose for energy. So they don't have to revert to breaking down cells for energy. There is no ketone production. If there's no ketone production, the pH is normal. The potassium should be normal, because on this side, the potassium levels elevate as a coping mechanism for acidic state. They're trying to shift hydrogen ion into the cell. So the potassium should be normal, and they will not have Kussmaul's respirations. Because again, there is no acid-base imbalance with HHS, all right? So, review, both elevated blood glucose levels. They cause 3 Ps. We're very concerned about polyuria because now we are going into a circulatory problem that mimics a dehydrated patient. So your priority, of course, is to administer fluids, okay? Typically, you see us give 0.9% sodium chloride. yes, we will administer insulin to decrease the blood glucose level, and it will be IV insulin, typically see regular insulin. On the DKA side is when we start to go into an acid-base imbalance because there's ketone production, which is an acid. So we start to go into an acidic state, our pH decreases, and our potassium elevates. We need to monitor the client's cardiac rhythms, their level of consciousness, and the insulin will assist to push the potassium back into the cell to lower our potassium levels. And for very, very severe clients that might not be coping and might be deteriorating, we might have to give sodium bicarb to help with that acid-base disorder. On the opposite end of the spectrum, HHS, there is no acid-base imbalance. There's no ketone production, pH is normal, potassium levels are typically normal. So we treat them with fluids and IV insulin, and we're not concerned about acid-base disorder. I do want to leave you with a little note to make sure that you are mindful when we intervene on these clients. When we are bolusing them with a lot of fluids, and when we are giving them IV insulin, we need to especially look for complications that may occur, such as hypoglycemia. We could bolus them too much and give too much IV insulin that they now go hypoglycemic, so always monitor the client for those symptoms. And then we also need to ensure that we do not drop the potassium level too low, because we know both clients get IV insulin, and IV insulin can move potassium from our blood into our cells. So you should always watch for the complication of hypokalemia related to treatment. Okay, thank you so much.